Hello, and welcome to Bite-Sized MRCP, a manageable way to digest the things that you need to know for your MRCP examinations. We are two junior doctors based in the UK who have passed all three parts of the MRCP within the last 5 years and want to help you do the same. We're not associated with any MRCP examination organizations, and the materials covered by no means is an exhaustive list of what can come up in your exam, and are not intended to be used as medical advice. Please refer to your College of Entry or your friendly supervisor for further questions regarding the exam and syllabus. If you like the sound of what you hear today and would like to join us for more bite-sized revision, give us a thumbs up and press the subscribe button. Now, without further ado, let's get into today's topic, which is on subacute cutaneous lupus erythematosus, which is under the section of rheumatology. So if you recall correctly, we talked about different classification of lupus. We mentioned that systemic lupus erythematosus, or SLE, is the phenomenon or the disorder that is frequently referred to as lupus. However, technically speaking, the other three categories of lupus are subacute cutaneous lupus, discoid lupus, and also drug-induced lupus. And we're going to be talking about subacute cutaneous lupus for the purpose of this talk. So what is subacute cutaneous lupus? Well, as the name suggests, it is only limited to the skin, and as we already mentioned, it's one of the variants of lupus. In about 5 to 10% of cases, it can progress to SLE, or systemic lupus erythematosus, later on. In terms of the epidemiology, it's far more common in females than males, and the peak age is about 20 to 50 years. So in that sense, it's really quite similar to your systemic lupus erythematosus. As for the signs and symptoms of the disease, it is classically described as a red, scaly, raised, ring-shaped rash on sun-exposed areas. So that's your face, neck, and arms. And it normally resolves, but it frequently does leave telangiectasia and also discoloration on the skin. However, importantly, it doesn't leave any scarring. So this is just supposed to be a picture of showing you a classic case of cutaneous lupus erythematosus. And as we discussed, you can see these quite raised circular scaly patches on this patient's chest and upper back. In terms of the investigations that would be sensible to do, really you should be, anyone who's presenting with that type of rash, first and foremost you need to be excluding a systemic lupus erythematosus. Because remember, a true SLE picture is a far more sort of serious or dangerous condition compared to a limited cutaneous version. Therefore, you need to be really thinking about all the immunological and histological investigations that you would do in a case of lupus. Please feel free to refer to our previous video on SLE, in which I go in in-depth details in terms of what those tests are. However, specific tests to cutaneous lupus, it's quite important to know that in this condition your anti-nuclear antibody can actually be negative, but remember, to have a systemic lupus you really cannot have a negative ANA antibody, and in cutaneous lupus you can still have your positive anti-RO and anti-LA antibody, and really the diagnosis, other than the classic dermatological manifestation that we just described, can be coming from skin biopsy. As for the management of this condition, like many other medical condition, you start with conservative measures, and that is to encourage the patient to avoid the sun, and also if they had to go into the sun, really wear high SPF sunscreen. You would encourage them to stop smoking, as with majority of the autoimmune conditions, the smoking is going to make the disease worse, and you would be supplementing vitamin D tablets should be needed. In terms of the medical treatment, you would start with topical or interlesional steroids, and then you can move on to systemic steroid, hydroxychloroquine or methotrexate in severe systemic cases. As for the complications of cutaneous lupus, the biggest worry really is progression to systemic lupus erythematosus, which obviously can, as I discussed, can be far more serious of a condition compared to a cutaneous version. As we discussed, it can leave the skin with discoloration and telangiectasia. However, it does not cause a scarring, and there is quite a niche association. However, it's one of those MRCP classics that is classically tested in your exam, and that's basically neonatal lupus. If you recall, we discussed the importance of anti-Ro and anti-Lo antibodies in a potentially a pregnant mother who has either SLE or cutaneous lupus, and it would be very important to be aware of that risk that having those antibodies positive in the mom can put the baby at a higher risk of having the neonatal heart blocks. And finally, and certainly not the least, is the psychological impacts that the patients normally have to suffer, unfortunately, to basically become comfortable, until they become comfortable with this condition as a diagnosis. And that's why it's very important for us in rheumatology and general medicine really to pair up with other members of the MDT, such as psychologists, to really be able to support the patient with their diagnosis. Okay, let's do some questions now. A 40-year-old lady of African origin presents with red, scaly, annular lesions on her face and neck, which had got worse during a recent visit to Spain. She smokes about 20 cigarettes a day. Which of the following is the most suitable first-line management option for her condition? A. Topical antibiotics. B. Topical antifungals. C. Smoking cessation, checking serum vitamin D level and applying high SPF sunscreen. D. Short course of prednisolone. E. Methotrexate. So if you go through this question logically, the stem should give you enough information that they're talking about an autoimmune condition, because you're dealing with a 40-year-old lady who's of African origin and is coming in with a scaly red lesion on her face and neck, which is a sun exposed area that has recently got worse after her visit to a sunny country. Therefore, really talking about antibiotic and antifungal is not going to make any sense in this case. So really you're left with options C, D, and E. And if you think about it logically, you would be thinking about conservative measures and first-line steps before putting people on sort of stronger immunosuppressants such as methotrexate or oral prednisolone. So by definition and by sort of having a good exclusion criteria, even if you don't know the exact condition in here, which is, by the way, obviously cutaneous lupus, you should be able to get into a correct answer, which is option C, which is smoking cessation, checking the serum vitamin D and supplementing as appropriate, and applying high SPF sunscreen. Question 2. A 30-year-old lady with cutaneous lupus has just given birth to a newborn boy. The newborn is found to have bradycardia and an ECG consistent with heart block. Which autoantibody is most likely to be responsible? This is quite a classic MRCP question, and the options that you've got in here is A, ANA or antinuclear antibody, B, rheumatoid factor, C, dsDNA, D, URMP, E, anti-Rho. So if you recall correctly, we did talk about the sort of the risk of mothers who have either SLE or cutaneous lupus and are found to have anti-Rho and anti-LA antibodies in their serum to be at risk of giving birth to newborns who could suffer from neonatal heart block. And this case is basically classically describing that. Therefore, the most appropriate option in here would be option E, or anti-Rho. Okay, thanks for listening to this episode of Biostiles MRCP. If you like the sound of what you heard today, give us a thumbs up and hit the like and subscribe button below to make sure that you don't miss out on our next episode. Let us know in the comments which topics you would like us to hear in the future. See you in the next episode.